I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation's educational webinar series, and I'm a patient living with MPA vasculitis. So these webinars are part of the Vasculitis Foundation's commitment to education and for patients, and we would like to thank our sponsors, AstraZeneca, Amgen, and Novartis, for supporting these webinars. Today's webinar is the Emergency Department and Patients with Vasculitis. I would love to introduce our guest speaker for today. Dr. Susan Wilson attended medical school in Chicago and completed an emergency medicine residency in Milwaukee, Wisconsin. She practiced emergency medicine in the Milwaukee area for 25 years, subsequently retiring in 2019. And as the parent of a young adult with EGPA, Dr. Wilson has both a personal and a professional interest in education and advocacy for those living with vasculitis. Following her retirement from clinical medicine, Dr. Wilson became a certified life coach, and she now helps clients achieve mental fitness. She and her husband, who's also a retired emergency room physician, split their time between Wisconsin and California. Well, welcome, Dr. Wilson. We're so happy to have you with us.
Well, thank you so much. It's great to be here, and I'm really glad that I have this opportunity to talk about something that's near and dear to my heart.
So I think, having said that, if that's okay, we'll move forward with your presentation, and maybe this will help us all with this topic.
Here we go. So what we are talking about today is navigating the emergency department, and specifically what you as a vasculitis patient need to know as you have this experience. So I thought first it might be a good thing to kind of talk through what the process is when you present to the emergency department. So the very first thing that happens is triage. It is a little different depending on whether you come in by EMS, which refers to coming in by ambulance, versus walking in through the front door and signing in. What happens is you go in. Let's say you walk in to triage, and the first thing that is going to happen is, finding out what your chief complaint is, getting your vital signs, and depending on what the acuity is of your complaint will kind of dictate how quickly you are put into a room. When we triage people in the emergency department, we kind of rank the acuity level. Acuity level 1 is the highest. So that is literally somebody that maybe usually comes by ambulance, is not breathing, they're in cardiac arrest. So that is the most severely ill patient. And then it's graded down all the way down to like a level 4 or level 5. So as you can imagine, the higher your number in terms of your acuity, the quicker that you will be brought into the back of the emergency department. When you come in by ambulance, the same general process will occur. However, there is usually communication between the ambulance personnel and the emergency department directly ahead of time, letting them know what kind of situation the patient is in, what the chief complaint is bringing the patient in. And so many times ambulances will be put into a room a little bit more quickly than somebody that walks in through the front door. That's not always the case, though. However, if someone, for example, calls an ambulance because they injured their ankle, and that's something that otherwise, would be a relatively lower acuity, they may come in by ambulance, but then they may actually sit and wait in the waiting room before they are brought into the back. So triage is the very first step. The sicker you are, the more quickly you are brought into a room. Then the second piece of that, again, the room assignment. And again, what room you're put in really depends on how severely ill you are. So someone that comes in, again, with something relatively minor, like a cut, like an orthopedic injury, those sorts of things will be in what we call treatment rooms, or more of a basic room. Someone that comes in short of breath, with severe pain, with chest pain, those kinds of complaints go into a room that contains additional equipment like monitors, ALS equipment. So that assignment kind of depends, again, on the acuity level. And then once you're put into a room, the evaluation and treatment begins. So the first step is seeing the healthcare professional. So whether you see a physician or a physician assistant, they evaluate you, they figure out what testing needs to be done, what kind of medications, treatments need to be done, and then you go ahead and receive those treatments. Now, as a patient, what should you be thinking about when you are going to go to the emergency department? So I think one thing to really consider is even before you make the decision that you are going to the ER, notification of your physician becomes very important. So, if you are going to the emergency department for a symptom that's related to your vasculitis, very important to contact that treating physician. So, excuse me, whether that is your rheumatologist, your pulmonologist, your nephrologist, it's really helpful for you and for the treating emergency department physician to notify that doctor, because oftentimes what will happen is that they will end up calling into the emergency department ahead of time and let the physician there know, hey, my patient is coming in, this is what's going on, this is what what their diagnosis is. They may have some suggestions of treatments that they would like to see done or certain evaluations. So that's a really important piece. Along those same lines, the idea of having a complete list of your medications and your problem list also becomes really important. So, we really want to know in the emergency department, what are your medical problems? So high blood pressure, diabetes, heart disease, vasculitis, and, of course, your specific type of vasculitis is also very helpful to know. Of course, it's really important to know your medications. And I think about most, if not all of you, are immunocompromised. And so really knowing, if you're on a biologic, if you're on prednisone, those sorts of things are very important. And so just having a list like that and just keeping that with you at all times becomes very helpful. And then treatment protocols. What I mean by this is if you have certain patterns of symptomatology that commonly happen to you related to your vasculitis, and you have certain treatments that are very effective for those, that's important information also to kind of note and be able to present to your treating physician when you go to the emergency department. So for example, if you have issues with severe pain as it relates to your vasculitis, maybe every few months you get a really severe vascular headache, and that there's a certain protocol that works very well for you for that specific issue, it's really very helpful both for you and for your treating physician to bring that information along. And that will probably also help facilitate your care in the emergency department. And then finally, PPE. I mean, I think this can't be stressed enough. You are an immunocompromised population. And as you know, the minute you walk into a hospital, you are exposed to any variety of infectious diseases. And so protecting yourself from infection becomes very important. So PPE, personal protective equipment, I think the most practical thing for you to have with you is an N95 mask. And just being able to have that with you, walk into the emergency department and being able to put that on for yourself is very important. As a caregiver, friend, or family member of someone going to the emergency department. So when you are in that role going to the emergency department, a couple of things there are important. Again, PPE, I can't stress that enough. The idea that, you walking in, even if you're accompanying your family member or a friend, being able to protect yourself with an N95 mask. So that becomes very important. Then the other thing to at least think about is to avoid unnecessary exposure in the emergency department. So when you go in with your family member, your friend, if you've identified that, you know what, this person is going to be in the emergency department for several hours, if you don't absolutely have to be there at the bedside, it's probably in your best interest to not expose yourself unnecessarily. So that's another thing to consider. And then finally, the third point as a family member or caregiver is the idea of maybe being able to get a private room. And again, this is something too that you can think about when you yourself are a patient. If it's possible, asking the triage nurses if the patient coming in can have a private room, because then that also affords you a little bit more protection in terms of exposure, unnecessary exposure. That may not always be available. If the emergency department is really busy, if the person coming in has something that's considered relatively minor, they may be put in a room that has a curtain separating two beds. But if it's possible, I think you will be accommodated. And I'm really bummed because my last slide was my best slide, and it was actually a picture of my son, Ben, and myself. And I just kind of wanted to bring it all home with the idea that, Ben and his journey to diagnosis was really the impetus for me becoming so devoted to this idea of really advocating for all of you. And I think also for me as a physician, recognizing how rare this disease is and how much, it's something that we don't typically think about when we're in the emergency department. So with that, I'm going to see if I can stop sharing my screen and if I can get back to the webinar. Okay, let's see.
There you are. Thank you so much for that. That was like super helpful already, just understanding the process. I have a couple of questions for you, though, just about yourself and your experience with your son, Ben. And speaking of Ben, I think we're going to see if we can unmute Ben and let him speak for himself today. Ben, for those of you that don't know, is a very big friend of the Vasculitis Foundation and did podcasts and things for lots of things for the Vasculitis Foundation. So, Ben, I can see you now. I hope you can hear us now and speak also. Can you?
Absolutely. No, so good to see you guys. Yeah, Kathy, thank you for including me in the young adult category, because I just turned 30, and that's, you start to get some angst over that. So thank you for that. And I look forward to seeing that picture later. I can only guess what it was.
Well, I was going to start by saying, Dr. Wilson, can you tell us how your experience as an ER physician helped you prepare and make best decisions when you were helping Ben navigate his way through the ER process? We're all hoping you had some magic ability that made life easier for him, but I'll let Ben and you both answer those questions.
Well, I will say, thankfully, Ben has not had to navigate the emergency department since he's been diagnosed. But leading up to his diagnosis, which was in the summer of 2014, he did have, and Ben was still in college at that time, he did have several trips to the emergency department while he was in college, while he was in other parts of the country. And so my husband and I, both being ER physicians, were trying to help him to navigate that, from a distance. And that was a little anxiety provoking for us, as you can imagine, as parents, just, not even as physicians, as parents. And at that point, I mean, he was really just presenting to the emergency department with symptoms that ultimately were diagnosed as vasculitis, but at that point didn't know it. So I would say that the one ER visit that really culminated in him having his diagnosis was the one I really felt that my connection in the emergency department helped. This was when Ben was actually home for the summer in Milwaukee, and he was having a myriad of symptoms, multiple organ systems. And we just realized, we can't try to deal with all this stuff at home anymore. He really needs to have everything figured out. And so I was able to call the pulmonologist in Milwaukee that had been seeing him, up until that time for what we thought was asthma. And so he knew that Ben was coming in. And so that, I guess, is a great example for everyone out there that, calling the treating physician that you have a connection with, that you're going in. And so they knew Ben was coming in. He went in, and I think the challenge, I in retrospect recognize the challenge of treating someone with a disease like vasculitis with all these different things going on when we're presented with that in the emergency department and we don't know the diagnosis. We're just it's sort of like you're trying to put out all these little fires. So, you're trying to make sure the breathing was stable, so treating the asthmatic symptoms and treating pain, treating dehydration, so treating all these things. And so I do think the big piece of that particular visit was the connection with the physician that had been caring for him ahead of time before I then had Ben go to my emergency department where I worked. So, I did have the advantage of having people around me that I knew, that I trusted, that I knew were going to take good care of him. And then he ended up in the hospital for a week. So
So that, all of that is great information anyway, but Ben, how did you feel about that visit in particular and your dealings with the ED, knowing you had two parents who are ED docs?
Sure. Yeah. And in a lot of ways, Kathy, that visit, it made me want to sort of look into more about the disease and just how I could help, solely because, you go in and you understand right off the bat, right? You've got a leg up when you have parents who are physicians who can help facilitate a lot of things. And you sort of realize, as I started to get involved with the VF and meet some other patients who many of them had wildly different experiences than I did. And you just realize, that's not fair. Like it shouldn't take having parents who are super experienced with this process and how it works for you to have a good experience. Like that's just not right. And that's, I think, where a lot of our work on the educational front has come in. I would say even with that though, it wasn't perfect. The way I would characterize ERs, anybody who's been in would basically say chaos is the best way to describe that situation in general. Even in my visit that ultimately led to diagnosis, where there were calls ahead, everybody knew what was happening. People knew knew my parents, knew my mom specifically, knew a little bit of the background of my situation. There was still a lot of chaos and sort of fumbling, so to speak, between some of the first people who saw me before I was admitted. It's sort of a story we can laugh about now, but I was, first given this giant cocktail of drugs just to get myself stabilized. And then they brought me in to get a chest x-ray, and there was just a lack of communication. And they, one didn't know that one part of the process had already started. And I literally collapsed, in the x-ray room because I was basically out of it at that point. They'd given me all these drugs and didn't communicate that had already happened, thought I could stand on my own to do the chest ray and x-ray and everything. And that's just, I think, a great, in a nutshell, description of what generally happens in these situations. I think back to a visit I had before that visit, it was probably several months before. And even at the time, going to a university clinic, right, where the resources aren't necessarily as great, more of a rural type location. And they didn't even know. I was coming in at that point just with asthma attacks before I was really diagnosed, before other symptoms started to develop. They literally didn't know to give me a nebulizer. I'm sitting there, you're a 20-year-old college kid, right? You just kind of assume, even regardless of whether your parents are physicians or not, you just assume if you go to the ER, they kind of know what they're doing. And to sit in there having an asthma attack, unable to breathe, and a physician is just sort of walking around, has no idea that you actually need something immediate. That to me was the obvious red flag of, this is not especially when you're talking rare disease and you're talking all the symptoms that we have, it's not something that you as a patient can just sort of sit back and hope for the best. Because I remember I think my dad had to literally get on the phone and say, hey, this is what you have to do. You have to give this patient a nebulizer right away. So I think that's kind of what goes into my biggest advice, is just to kind of build off the analogy of all the little fires, which I think is a really good way to think about it. When you come in, I think the benefit of having a diagnosis and knowing your body at that point, at least a little bit better than maybe say someone like I did when I didn't have a diagnosis yet, is to at least isolate, okay, what's the most important thing right now? Like, what's the most important of the fires? And let's just start there. And I think that way, by having that mentality and just being able to have that sort of communication with whatever nurses or first doctors that see you, to me, that's what helps mitigate a lot of that chaos and just makes it easier for everybody. It's not a perfect solution, but certainly to at least go and say you have EGPA like I do, and to be able to go in the ER and say, hey, look, I've got a lot of different, I have a rare disease. There's a lot of different elements to it. But the most important part is I need to be stabilized breathing, because that was always the first thing for me that would cause everything else. And that's kind of the way I've seen it. And it's sort of wild to me that it's been July 2014 was when I was diagnosed, and just celebrated my 10th anniversary. So fortunately haven't had to go back in some time, but I still remember it very vividly, I think, as anybody in my position would, when it's something that serious.
Well, Ben, thank you so much for sharing both perspectives, the perspective of before you knew what it was and you just simply needed a nebulizer and somebody to advocate for you. But now that's great advice. Make sure that we as patients say, hey, this is the thing that's most important right this second. You know, we can deal with the other things after that. What great advice that was. Dr. Wilson, can you tell us what some of the biggest challenges or gaps you saw in the ER process when you were, with Ben as a patient and you as a caregiver? Like, did you see things that you felt like you needed help correct?
Well, I think Ben's example that he gave about, being in a relatively small emergency department, and they didn't do what my husband and I know is to be the standard of care, right? Nebulized medication for asthma attacks, IV steroids, so yes, definitely that was a frustrating thing for us, knowing that was happening. I will say that I think one thing to keep in mind with the emergency department is, when you go in, regardless of what the complaint is, and I guess when I say regardless of complaint, I mean, let's just say we're just focusing on medical complaints, not, things that are unrelated to your vasculitis. So if you're in having a complaint that is related to your vasculitis. So I think the thing to keep in mind is we've all been trained, in emergency medicine to focus on the ABCs first, ABC. So A is airway, B is breathing, C is circulation. And so, so airway is the first thing, making sure someone's airway is patent. B is breathing, making sure they're breathing on their own. I mean, if someone is not breathing on their own, that's when, they have to be put on a respirator and you have to be more aggressive. And then the C is circulation, which refers to, does somebody, is their circulation adequate? Do they have a good blood pressure? Is their heart beating normally? Those kind of things. So that subconsciously, that's always going through our mind, the ABCs. And, once you've established that those things are all in order and those things are stable, then you move, then you continue on moving through, okay, well, somebody is coming in now, they have severe pain. How do I deal with that? How can I treat that? I do think the other caveat with vasculitis patients is just continuing to remind yourself that this is a very rare disease. And I will be completely transparent here and say that I didn't really even have vasculitis on my radar as a physician working in the emergency department until my own son was diagnosed. I mean, I just saw him having all these weird symptoms that just didn't seem to fit. And it really wasn't until I had the experience, as his mother, and then that really helped me learn a lot about the disease process, as a physician. And so I think reminding ourselves that, yes, this is a rare disease. Probably a lot of physicians, it doesn't come to the forefront of their minds. And it's only after a lot of other things have been ruled out that then this does. So when you're interacting with someone for the very first time in the emergency department, I think that may be something that you experience as somebody that doesn't even think about vasculitis. And so again, you advocating for yourself, being very forthcoming with, this is my diagnosis, these are my meds, this is what has worked for me, those sorts of things, I think is very, very helpful and will lead to a much more satisfactory visit.
Well, thank you for explaining that, because I never knew that. And it's really good to hear what the emergency room physician is thinking about when they're looking at people. And Ben, I wanted to say thank you to you. I know you had limited time with us today, and we appreciate you giving us your thoughts on that. Is there any last things that you want to say before we move on to asking your mom all kinds of questions?
No, thank you. Thank you so much for giving me a few minutes to speak. So glad I could join and contribute. I think my closing word and comment, just thinking about where this is not necessarily just on this topic, emergency department, but just as a whole, I certainly believe, coming up on 10 years of an anniversary being diagnosed, certainly that's a time for reflection. And I certainly believe we've made a lot of improvements as far as the education, as far as patient advocacy, just getting better and giving patients more confidence to speak up and really advocate for themselves in those sorts of situations. So I think these sort of things are just a good reminder to help encouraging people do that, because there's always new people getting diagnosed. I think we've kind of realized it is still a very rare disease, but maybe not as rare as initially thought. As the process of diagnosis gets better and more efficient within different hospital clinics. So to me, it's a great opportunity as we welcome more people into our community, just to give them those sorts of resources and insights that can make any sort of, like in this case, a trip to the ER a little bit more manageable.
Well, thank you so much, Ben. We miss you and your podcast, and we appreciate you being on here today. And happy anniversary, 10 years.
Thank you. Thank you.
Well.
Appreciate it.
Okay, and moving on to asking Dr. Wilson more questions. Some of the questions that we had for today, you've actually already answered in detail, but one that I did want to go over while we're waiting for some of the patients that are watching today to put their questions in the chat box is why do you think the ER environment itself is such a challenge for attending physicians when someone presents with symptoms that are associated with diseases like vasculitis? I mean, my brain is just going all sorts of directions. And when someone comes in with a rare disease like vasculitis, that, like you said, you never thought of it. So is there anything else that we can say about that makes patients feel better? But I mean, limited decision making, I guess, limited knowledge.
Yeah, well, and I think, again, getting back to this idea of the ABCs, and again, we as physicians, that's something, it happens so quickly. I mean, you and I are talking here. If I walked into your room and to see you, and of course, you're talking to me, so obviously your airway's okay, you're breathing fine, and obviously you're sitting upright and you're awake and alert, and your circulation is fine, right? So those are things that happens like a split second in our minds as physicians. And then we move on to really trying to, I kind of made the analogy of putting out fires earlier when I talked about Ben's experience, but we kind of go then into, okay, what are the symptoms? And, how do I treat these symptoms? And so, for example, like in Ben's case, when, he would present to the emergency department with what we would call an asthma exacerbation, right? Or bronchospasm. We as physicians are very intent on treating those symptoms. So, okay, how do we stop this person from wheezing, and how do we stabilize their breathing? Somebody comes in with severe pain, right? And this maybe is related to their vasculitis, but they come in with severe pain. Okay, how do I get their pain under control? So it's I kind of think the mindset that we have that then probably makes this whole situation very challenging is looking at the symptoms and trying to treat those symptoms. And then only after kind of getting symptoms under control, being able to then take a step back and figure out, okay, well, putting this all together, what do all these symptoms, what's going on here? Coming to a diagnosis. I think one thing that I always loved about emergency medicine is that you never know what's going to come in the front door. And, it's always like nobody comes in with a label on their forehead saying, I have a kidney stone, or nobody comes in saying, I have pneumonia. It's like they come in, they tell you how they're feeling, what their symptoms are, and you have to figure it out. And so that, I think vasculitis is probably one of those, great puzzles, if you will, where there are so many different symptoms that you may have, and then being able to assimilate all that and put it all together and figure out, okay, this is all because of this patient's vasculitis, or, and the thing is, I think also recognizing, I mean, we've all been taught in the emergency department to think the worst and work backwards. So, if you come in and you say, I'm having chest pain, well, I'm not going to immediately assume your chest pain is because of a flare-up of, your vasculitis, which sometimes causes you to have chest pain. I'm going to think, oh my gosh, I need to make sure you're not having a heart attack, or you don't have a blood clot in your lung. There's I think on that note, also people with vasculitis have to recognize that, not everything that happens to you is going to be directly because of your vasculitis. You can still have a stroke. You can still have a heart attack. You can still have, a bowel obstruction. I mean, there are so many other things that maybe are symptoms that you present to the emergency department with that ultimately it isn't related to your vasculitis, but we have to kind of keep an open mind. And so there is a lot of challenge there.
Well, I mean, that's a great answer to make us all understand a little bit more about what's going on through the head of the emergency room doctor. And clearly we're talking about two different situations. People who come in and have not yet been diagnosed, and people who've come in and have been diagnosed. And actually the questions from the patients today are all over these areas. So I am going to ask you some of their really great questions. And one was, and I don't know if you know this one, but I was told by someone that Medicare people cannot get a private room. So I would imagine if the doctor requests it because of immunocompromised status, that it could be approved. Do you know what would happen in that circumstance?
Well, I will say I've actually never heard that a Medicare patient can't get a private room. Now, maybe this is in reference to being admitted to the hospital.
Yeah, maybe.
And I'm just thinking about, within the emergency department. I mean, that's kind of the area that I'm familiar with. So when I'm referring to getting a private room, I'm talking about within the emergency department. So I can't really speak to, Medicare rules and regs once somebody's hospitalized, but yes, for sure. If and people come into the emergency room all the time, even prior to COVID, somebody would come into the emergency department if you suspected they had TB, for example. They were immediately put into a negative pressure private room, right? To protect everybody else in the emergency department, right? You don't want TB all over the ER. So the same kind of thinking would apply, that if, let's say you come in at 7 a.m. to an emergency department, it's not very busy, and you have you're coming in because you have an ankle injury, you need an x-ray, and you're going to be around for a while. Or if it's a medical thing, you're having an asthma attack or whatever. But I think if you're coming in and they have room and you say, look, I'm immunocompromised, do you have a private room for me? I think that will be accommodated for if possible.
Yeah, that sounds correct, but it was a good question.
Mm-hmm.
The next question is, my primary vasculitis providers are out of state in a different time zone from me. I have a strong local team, multiple specialists as well, but I'm concerned about coordination in the event of an emergency now that I'm confirmed with, living with vasculitis. Any recommendations, particularly as a single person, often presenting to the ER on my own? I think everybody worries, can I get a hold of my doctor? How do we do that?
One thing I didn't specifically address, but I think would also be very helpful, along with your list of your problem list, right, of your medical problems and your medication list, is having your physician's names and phone numbers, and just having that list. And especially, if you have multiple specialists that you see, you have your rheumatologist, you have your nephrologist, and if you have your out of town specialist, that you see, I think it's very helpful to have those numbers. And then if it becomes apparent that those people need to be contacted immediately in the emergency department, your treating physician in the emergency department then, has a way to contact those people.
Yeah,
And
I was just going to reiterate, I mean, experiences that I've had as a vasculitis patient in the emergency room. I went to the emergency room where my doctor practiced in that hospital, and said, you guys have to talk to him before you do anything to me. And then I said, I'm in kidney failure, and everything went very smoothly after that. So there was a question about what is the best way for us to have information when we go to the emergency room. Should we have printed out information about vasculitis? Should we have it on a thumb drive about our own personal experience? What helps you as an emergency room doctor quickest, or what do you prefer?
well, I think, again, I think having very succinct lists is very helpful. I mean, I have had patients come in with, 3 pages of every single medical thing that has ever happened to them, starting from in 1940, I had my appendix out, and that kind of stuff. I mean, that is very important to keep a record of that. But I think for the emergency department, trying to keep it very succinct is really important. Medication list, problem list, physicians and physician numbers. And I would, a couple of things I thought about this. So, in this day and age of electronic medical records, if you end up accessing an emergency department within the health system where your physicians work, there's a lot of stuff already in the system that the ER physicians can access just on the computer, right? I mean, like clinic notes and lab tests, they can readily compare what was your creatinine, a month ago compared to what is it now today in the emergency department, those sorts of things, scans and all that. So that is very helpful. If for some reason you are going to an emergency department outside of the health system where your physicians normally practice, I do think just having it literally in a document, whether it's a document you keep in your phone or, literally a piece of paper, I think that is helpful. I don't think necessarily having a thumb drive that a physician then would put into a laptop is necessarily going to be helpful, because a lot of times physicians work on, computer terminals that are within, they're a hospital intranet system, if you will. And so while they can Google a lot of stuff and they can go on the internet and on certain approved websites, I don't know how easy it would be for them to just take a thumb drive and plug it in somewhere.
Yeah, or how cool the hospital would be about introducing some random person's thumb drive into their magnificent system.
Right.
I'm getting this question in a couple of different ways from a couple of people, so I thought I would just generalize it. I've found that when I tell a doctor about my vasculitis, they kind of nod their head, but you wonder, like, do they understand that this is a life-threatening illness? Is there some other way we should phrase it other than the words, microscopic polyangiitis, vasculitis? Like, are we doing too much or too little? How do we handle that?
Well, I think the first thing that comes to my mind is, really any disease process potentially can be life-threatening, right? I mean, diabetes, heart disease, high blood pressure. I mean, they all are. So I think the biggest piece of information to try to get across, if you feel that the physician isn't necessarily really hearing you or getting, the implication of the vasculitis diagnosis, is really emphasizing, hey, I am immunocompromised. Because I feel that, that really, there are so many scenarios where being immunocompromised really does, that really does change your treatment plan, maybe changes your ideas of admitting somebody to the hospital versus outpatient treatment. So I think if you're finding any resistance to someone really appreciating the fact that, you have vasculitis, maybe even just saying, I have EGPA, I'm immunocompromised, and this is why, and so I think that definitely gets people's attention.
Okay. And the next question is, if your doctor sends you directly to the ER to confirm a diagnosis of vasculitis and sends you with copies of their findings and calls the ER and notifies the hospital that the patient is coming, do the ER docs still do the ABC approach and do a complete workup, or do they move towards what the doctor who called in and said things, do they move in that direction?
Well, I think what happens, at least my experience is, yes, I mean, ABC is always, going to kind of be the first thing. And again, as I said earlier, that may be even done within, half a second. You walk in the room, you realize this person's ABCs are fine. And now we're moving on to what are their symptoms. What my experience has always been is, you get the phone call ahead of time. Hey, Mrs. Smith is coming to the emergency department. This is her diagnosis, or I'm suspicious this is what's wrong with her. We would really like to get, this scan. I would really like you to get these blood tests. And so yes, you take all of that information and, add that to what you're already thinking as well. And so there's probably some duplication of things. Like, if I saw someone and depending on what their symptoms were, I thought, yes, this person does need a CT scan of their chest or whatever. And maybe their referring doctor had said, yeah, I want them to have this certain scan, or maybe I had already thought, yeah, I definitely need to get this blood panel, this blood work done. And that is part of what the referring physician suggested. So I think it's, the two kind of work in concert with each other. I think what ends up happening a lot is, there may be some basic things I would order. And then if the physician calls in and says, hey, I also want you to please make sure you get a SED rate, or please get a rheumatoid factor, or please get an ANA or can you order an ANCA level? That's not going to come back right away, but I want that, those sorts of things. Those are things, yes, then we always add those on to our own, the basic workup that we do too.
Great. It's really good for us to hear that from you so that we feel more confident. So I'm going to do a confessions of a vasculitis patient thing here so that you can share what I did wrong with everybody, because we talked about this. I recently was in the emergency department with my father, who's 93, who had a cough and was taken there by EMS. And we were put in a room that was a split room. Like there was a curtain between us and there were people like you couldn't walk past my dad. It was really close. And this person over here was coughing their brains out. They had a mask on. My father did not have a mask on. I did not have a mask on. I, of course, wound up sick a few days later. And I'm sure you would like to make a point of what I should have done in that circumstance.
Well, number one, I think that's a very reasonable situation, a very reasonable scenario to request a private room. Now, it may have been that the emergency department you were in, maybe they were full, and maybe this was the only arrangement that they had in terms of being able to see your father and treat him. And, they still had so many other people. But yeah, so requesting a private room in that situation, not only for you, but, your dad who's coughing and stuff, I mean, that would be very reasonable. Number two, again, just having an N95, just carrying it around with you and having that and just accepting the fact that, when I walk into a hospital, and it doesn't even have to be the emergency department. If you're walking in, you're going into some lab, to get monthly blood work done, or you're going in to get some kind of imaging study in the outpatient radiology area. I mean, it's very reasonable to just go ahead and put a mask on.
Yeah, I knew you were going to say that to give everybody that opportunity to hear what I did wrong. My doctor also said that to me a couple of days ago when I was at the Vasculitis Center in Chapel Hill, North Carolina. Why weren't you wearing a mask? Don't you have one? I said, of course, there's one in my glove box.
Mm-hmm.
But thank you for sharing that. I think we honestly covered everybody's questions, unless I missed something. I didn't mean to miss you, but I think we covered everything. And I appreciate so much what you said about all of the different aspects of the ED. I don't think most of us understand it. And I think this gave me a way to advocate for myself. I think a lot of us worry about how are we going to do that if we, get in this situation. There was one more question that I forgot to ask you, but it was somebody said, does it make a difference if your doctor has admitting privileges in the ER that you go to?
You probably mean in the hospital you go to. It really doesn't. It does make it easier if you anticipate, like if you feel like, you know what, I think I'm going to end up in the hospital. I mean, you know your body and you know your vasculitis and when you're having flare-ups and such. If you anticipate you may need to be admitted to the hospital, if the hospital where your physician is on staff is close, I think it's reasonable to go to that place, because otherwise what happens is, and again, this can be done and it's done all the time, but it's just a little bit more of a laborious process, is let's say you show up in emergency department, and it's determined, yes, you do need to be admitted to the hospital, but you want Dr. Smith, who doesn't come to that hospital, he goes to a different hospital across town. Arrangements can be made to transfer you, but then there's caveats. Well, is the hospital where Dr. Smith is on staff, do they have beds? Can they take you as a patient? Are you going to have to sit in the emergency department for 12 hours waiting for bed? So those things become issues, but it's not insurmountable. So anything is possible. I would say definitely, if you have symptoms where you are feeling that you're in significant distress, you don't want to spend an extra, 30, 40 minutes driving yourself somewhere else because that's where your doctor is. If you're really in acute distress, you need to get to the nearest place. And again, I know we touched on the EMS versus walk-in part of triaging, but I think it goes without saying, if you have symptoms that are significant, that you feel are really, you feel it's a life-threatening thing, or you feel that this is something that is really severe, then you should just call 911, and an ambulance will take you to the closest facility.
I mean, that's so important also. And I just want to say that when I was in the early stages, my first 6 years were really bad, a lot of visits to the emergency room.
Mm-hmm.
My local county has a thing that you can sign up for EMS. You can pay $60 a year, and then all of your transportation are free. So it was a no-brainer for me to call EMS if something was going on. It was safer for me to do that, so I did. It sounds like your emergency room experience can be different when you're presenting with symptoms and you don't yet have a diagnosis versus going to the emergency room and you already have a diagnosis. Would you say that's true?
I would say that's very true. I mean, obviously, my experience with my son, with Ben, I mean, his ED experiences were all prior to his diagnosis. So, he again was somebody that was presenting, they were treating his symptoms, and his symptoms that primarily were addressed were his respiratory symptoms. So, he was presenting like an asthmatic. I mean, this was, the effects of his vasculitis on his airways, on the blood vessels in his lungs. And so it was obviously a little bit different situation, but, at the end of the day, it was still treated the same. But yeah, there's definitely a difference in that. But then, if somebody's already been diagnosed, they come to the emergency department, and let's say they're having severe pain, which they know from past experience, that has been related to an exacerbation of their vasculitis. They may end up being treated similarly to someone that, you didn't know that was a diagnosis, but it is very, very helpful if you know that going in that this is what they have. And as I kind of alluded to earlier, if you have a protocol, that works for you when you have an exacerbation of something, it's really, really helpful to have that written down as well and bring that in with you.
Yeah, I mean, that piece of advice right there is very important. Lots of us have had our doctors say to us, well, what antibiotic works on you? So I'm sure that it does help if we know certain things about our vasculitis at work, we can help the doctors. Well, I appreciate so much the time you spent with us. You cleared up so many things for me. I'm sure for everybody else, there have been a lot of compliments in the chat box about how much they learned today. So thank you so much, and we appreciate it. And we really appreciate you being Ben's mother and helping him through this journey as well. So thank you, everybody. I think that's a wrap for today.
Well, thanks, everyone.
I did also want to say something just before we go about the VPPRN. But first, I want to say, hopefully you can see my screen. Thank you to Dr. Susan Wilson. Thank you to the Vasculitis Foundation for supporting these patient education webinars, and our sponsors, Amgen, AstraZeneca, and Novartis. And everybody, we appreciate you being here.
Thanks, everyone.